Hello everyone, this is Dr. Meghna and welcome back to my channel. I'll be discussing the important concepts of cherubism, including the etiology, pathophysiology, clinical features, radiographic features, histopathological features, diagnosis, and treatment. This video will be of great help to give your university exams. So, try not to skip the video. Cherubism. It is a genetic disease affecting the jawbones of children. Jones described it as the familial fibrous dysplasia of jaws and named it cherubism. Cherubism is a specific hereditary form of fibrous dysplasia. Fibrous dysplasia is a non-hereditary bone disorder where normal bone is replaced by fibrous tissue. Cherubism is a hereditary form, fibrous dysplasia is a non-hereditary form. Okay. Coming to the etiology. Mutations to the SH3BP2 gene cause most of the cases of cherubism, over 90%. The SH3BP2 gene tells your body how to make the SH3BP2 protein, which plays a role in replacing the old bone tissue with new bone. This protein helps in bone remodeling. Okay. Mutations cause your body to make too much of SH3BP2 protein. Too much of this protein leads to inflammation in your jawbone and increased production of osteoclasts. These osteoclasts are the cells that do the important job of breaking down bone tissue when your body doesn't need it anymore. Bone resorbing cells, okay? But in excess, osteoclasts start breaking down bone tissue in your jaw when they are not supposed to be. This abnormal bone loss combined with inflammation from excessive SH3BP2 protein causes cyst-like growth to develop in your jaws and hence described as multilocular cystic disease of the jaws. Coming to the clinical features. It's common in children between 14 months to 3 years, or in some textbooks it's mentioned as 2 to 7 years of age, and hence is called the disease of children. It manifests as a painless bilateral symmetrical enlargement of the maxilla and mandible. Cherubic face. This appearance is due to symmetrical and bilateral enlargement of both the jaws resembling plump-cheeked angels. Chubby-cheeked angels in Renaissance paintings mimic the cherubic faces. Okay. This cherubism or bilateral enlargement of the jaws progresses until puberty. It regresses after puberty. Resolution or typically it gets to normal by the second decade of life. The next is the eye to heaven or angelic appearance. An upward glaze occurs due to the expansion of maxilla involving the orbital rim. This leads to exposed sclera, which in turn tilts the eyeball upward. The final result of these physiological changes is the blurring or loss of vision. Coming to the lymph nodes. Cervical lymphadenopathy is seen. This cervical lymphadenopathy, along with the bone enlargement, makes the face round and gives a full moon face appearance. The next is the Arnott's classification. Arnott's classification, also known as the Raman and Engelberg classification, is a system used to categorize cherubism based on the extent of jaw involvement. It categorizes cherubism into 4 grades, with each grade representing increasing severity and extent of the lesions. Grade 1. There is bilateral involvement of the ascending rami of the mandible. Both the ascending rami are affected in this case. Grade 2. Involvement of mandibular ascending rami as well as maxillary tuberosities. Grade 3. There is massive involvement of the entire maxilla and mandible excluding the condyles and coronoid process. Grade 4. It is similar to grade 3 but also includes involvement of the orbits, potentially causing orbital compression. Let's get into the histological features. This should be mentioned under four headings. One is the fibrous connective tissue stroma, second is the giant cells, third is the vascularity, fourth is the perivascular cuffing. Let's get into the connective tissue stroma. The normal bone architecture is replaced by proliferating fibrous connective tissue, which can be dense or loose depending on the stage of the lesion. Let's see how the giant cells are. There are numerous multinucleated giant cells resembling the osteoclasts. These cells are positive for tartrate resistant acid phosphatase. This is the feature of osteoclasts. The fibrous tissue is typically highly vascularized, containing numerous blood vessels. Perivascular cuffing is distinctive but not always present. There is an eosinophilic perivascular cuffing of collagen surrounding small capillaries within the lesion. You can see in this histological picture. Also, there are areas of hemorrhage and hemosiderin deposits, brown pigment from blood breakdown products. Let's get into the radiological features. It should be mentioned in the following side headings: location, periphery, internal structure, effect on adjacent structures, and effects on adjacent teeth. Coming to the location, the lesions of cherubism are bilateral and both jaws can be affected. But when present only in one jaw, the mandible is the most common location. The epicenters of these lesions are always in the posterior body and ramus of the mandible or in the tuberosity of the maxilla, mostly in the posterior region. Okay. Coming to the periphery. The periphery is well defined and corticated. Let's see the internal structure. The internal appearance of cherubism is very similar to the appearance seen in central giant cell lesions. That is, there may be fine granular bone oriented and wispy striations, imparting a multilocular pattern to the lesions. Coming to the effects on adjacent structures. Expansion of the surfaces of the maxilla and mandible by cherubism can result in severe enlargement of the jaws. Maxillary lesions can displace the maxillary sinus floors, and in the mandible there may be substantial displacement of the medial and lateral surfaces of the ramus. Of particular concern is that extensive medial displacement of the soft tissues can compromise the airway, leading to obstructive sleep apnea. Let's get into the effects on adjacent teeth. Because the epicenters of these lesions are in the posterior mandible or maxilla, the teeth are displaced towards the midline, that is in the anterior or medial direction. The degree of displacement can be severe and developing tooth burrs may be aggressively disrupted with some lesions. There are multiple unerupted teeth which appear to float in the cyst-like spaces within these lesions. This gives a floating tooth appearance. There is another important feature, the hard palate sign. It's the visibility of a significant portion of the hard palate on lateral skull radiographs due to the absence of posterior maxillary teeth. You can appreciate the hard palate sign in this radiograph. Although the radiologic appearance of cherubism are similar to central giant cell lesions, the fact that cherubism is bilateral with an epicenter in the posterior mandible and maxilla should provide a clear differentiation between these two. The differentiation of cherubism from fibrous dysplasia should not present any difficulties because fibrous dysplasia is more commonly unilateral. Also, the sometimes multilocular appearance of cherubism and the aggressive displacement of teeth and disruption of the tooth follicles are more characteristic of cherubism. Cherubism may also have some similarities to odontogenic keratosis in nevoid basal cell carcinoma syndrome. The bilateral symmetry of cherubism Anterior or medial displacement of teeth and multilocular appearance are the characteristics that help with the differential interpretation on the radiographs. Coming to the treatment, mostly observation and monitoring. For mild cases, regular checkups and imaging like X rays, CT scans to track the progression of lesions are usually sufficient. Surgical intervention is usually delayed until after puberty, when the condition is likely to stabilize or regress. Surgical intervention includes curettage, which involves removing the abnormal tissue from the affected bone. Contouring or reshaping the jawbone to improve its appearance and function may be done. Partial resection or removing a portion of the affected bone is done in severe cases. Hope I have made these concepts clear. You can take a screenshot of this chart. I have exactly written this in my university exams during my bachelor's. This would make your learning interesting and easy. Let me know if you want me to explain any other topic. Comment your doubts and subscribe